Good afternoon. Good afternoon. So we are excited today. We have an amazing speaker. But before we start, I wanted to just give us a little brief introduction. MD Newsline is a health disparities focused educational platform for healthcare providers and healthcare influencers. It is our mission to increasingly access to culturally relevant and accurate research and resources. Our experts and advisors and editorial contributors are dedicated to curbing health disparities while helping to take a more culturally sensitive approach to patient treatment and disease management. Please be sure to follow us on Twitter, on Instagram, at MD Newsline, and visit mdnewsline.com today. So we are excited. Dr. Joyce Ip is an expert in cosmetic and surgery and surgical medical dermatology. She has over a decade of award-winning experiences and specialized in expertise in dermatology. Dr. Ip works closely with each patient to get to the root of their health and skin concerns. She prides herself on developing a nurturing relationship with each patient, balancing the expert opinion and treatment plans with a level of warmth and humor that puts everybody at ease. She's a native Boston, Massachusetts resident, and she graduated from the Harvard University with her bachelor's degree in health policy, and then traveled to the United Kingdom to pursue her master's at Cambridge University. At Cambridge, Dr. Ip studied international development, graduating with high honors after receiving her medical degree from Cornell University, Wales Medical College. She completed her and specialized her training and specialized in dermatology at Dartmouth Medical Center while she served as chief resident in her final year. Dr. Ip is a medical journalist and media expert and has been an expert contributor to numerous magazines, including O Magazine, Marie Claire, Dr. Oz, The Good Shepherd, In Shape, and Cosmopolitan. She also appeared on a national television, including the Wendy Williams Show. She is a faculty member at the American Academy of Dermatology, the New England Dermatological Society, and the American Society of Laser Medicine and Surgery. Dr. Ip is committed to providing comprehensive, cutting-edge, compassionate care to her patients of all ages and skin types. Her areas of expertise includes injectable fillers, laser treatment, chemical peels, acne, hair loss, scalp disorders, skin cancer detection, and pediatric dermatology. She stays current on the safest and most successful skincare procedures and products. And shares information with all of her patients throughout her tenure. We are happy to have Dr. Ip. Can you this is amazing. We are just so excited. Why don't we get right in? Well, let's don't waste a moment. Dr. Ip, can you tell us what is atopic dermatitis?
Well, first, Dr. Pete, I wanted to thank you for having me on MD Newsline. Awesome. So let's talk about atopic dermatitis, something that's really relevant in the colder months that we're in right now. So atopic dermatitis is often called eczema, and it's an inflammatory skin disease. And atopic dermatitis is extremely common. So about 1 in 10 Americans will have eczema in their lifetime. And one of the things that, I'd like my patients to understand is what is the meaning of eczema? So eczema comes from the Greek, and it means to bubble over. And that is like describing what's happening to your skin. So if you look at the skin of a patient who has eczema under the microscope, you're actually going to see swelling of the skin cells. And that swelling causes inflammation that leads to intense itch. Okay, so that's where that kind of describes the clinical picture that we see in eczema. So a lot of my patients like to ask me, well, doctor, why do I have eczema? what causes eczema? And the simple answer is we don't fully know. But what we do know is that there's a complex interplay between genetics, immune factors, and environmental factors that determine whether or not you have eczema. So the way that I like to describe our skin is that our skin is supposed to be like a brick wall. And that brick wall is supposed to protect us from infections and toxins coming into our skin and from moisture and water leaving our skin. Okay. So in our patients with atopic dermatitis, their brick wall, the bricks don't have that glue holding it together, that mortar holding it together. So they have gaps in their brick wall. Okay. And those gaps in the brick wall allow infections and toxins to come into the skin and allow moisture and water to leave the skin. And this kind of helps to illustrate some of the problems that we deal with in our eczema patients.
So would you say, and I get this question all the time as a primary care internist, what sort of dietary interventions can patients do? Many of the patients I don't want any prescriptions. What sort of lifestyle modifications, dietary things can people do to help with their eczema?
So I think the first thing that we need to recognize is that eczema is not really connected to diet. Okay. Atopic dermatitis is part of a constellation of symptoms that we call atopy. So it means it's related to a lot of other things like allergies, seasonal allergies, asthma, hives, some food allergies, and asthma. And these are all related. They're like on the same genes, but they're not the same thing. So often patients think that, hey, I can change something in my diet and that's going to fix my eczema. And that's not the case, really. What will fix your eczema or what will prevent your eczema is working to maintain the barrier function of your skin. So if we go back to that brick wall, we know our patients with eczema have holes in their brick wall. What you need to do to prevent that is to make sure that you do things to help fill in those gaps, so to speak. Okay. Yes. And so what I educate my patients about are lifestyle things that make it less likely for them to flare from their eczema. So that includes taking shorter showers, because when you shower, that opens up all of your pores and allows more water to go out of your skin. So you want to take shorter showers. You want to use lukewarm water instead of hot water. And it's really important that you avoid harsh soaps and things that have fragrance and dryer sheets and things like that. And after you come out of the shower, you want to pat your skin down, and then you want to use a thick emollient cream every single day. And you want to, lubricate your skin from head to toe. So that cream is kind of helping to fill in those gaps, right? And that helps to prevent things from coming in and things from going out. Sometimes if you notice that you're particularly dry in one area of your body, you can layer up with an occlusive agent like Vaseline on top of it. So for me, for example, I have mild eczema and I have to wash my hands, you and I, tons of times a day. So what I'll do in between patients is that I will moisturize with cream and then I'll put Vaseline on top. And so that's just an extra layer of protection so that my hands don't start to break down. You can also do things like put a humidifier in your room in the winter months, right? So during the winter months, particularly in Chicago and Boston, where I live, people are cranking the heat, and that heat is dry and it's drying out your skin. So if you suffer from eczema, one of the ways that you can help to minimize some of those side effects is by putting a humidifier in your room.
Wow, this is very helpful. Would you say that atopic dermatitis presents itself differently for various ethnicities? So would it present differently for, let's say, African American patients as opposed to European American patients?
I mean, I think that one of the things that I notice that's the most different between those who have skin of color and those who have Caucasian skin is the prevalence of eczema. Okay. So the prevalence of eczema is almost twice as high in people who identify as Black or African American, and 7 times higher in people who identify as Asian, right? So this is really important data, right? So we know that we have a higher burden of disease, but the problem is there's not a lot of research on treatments, that look at people with skin of color to see how those treatments work. But there are some differences in clinical presentation that sometimes we see. So people with skin of color tend to present with diffuse dryness all over their skin, and they're more likely to have something called lichenification. And lichenification is basically when your skin looks like leather, basically. It looks like and feels like leather. Another thing that we see more commonly in skin of color with eczema is dyspigmentation. So dyspigmentation meaning the skin gets too dark or it gets too light because of the inflammation associated with the eczema.
Wow, this is great. So, Doctor, take us through the spectrum. So, someone comes to see their primary care physician. What are they typically getting in terms of treatment? And then when should that escalate to a referral to see a specialist like yourself?
I think that one of the things that's really hard about skin disease in particular is that that doctors actually don't get a lot of training in skin disease. And one of the things that my patients will come to me and they'll be like, well, why can't they always say my doctor didn't, figure this out, as if I'm not a doctor, right? They're like, my doctor didn't figure this out. I'm like, you have one right here. And I like to explain to them that, you're getting a week, maybe 2 weeks of dermatology at best. So what I try to educate my primary care, you two at best. Whereas to become a dermatologist, I actually have to do 1 year of internal medicine, right? Internal medicine is 3-year residency. I have to do a third of it, right? So I was like, you want me to manage your blood pressure? We have this friendly banter about it. So one of the things I try to talk to my primary care colleagues about is having a few medications in your toolbox that you feel comfortable with giving to your patients. A low potency steroid, a mid potency steroid, and more importantly than the steroids, I think is just being familiar with the skincare stuff. Because I always tell my patients that the medicine is only 50% of it, right? The other 50% is how you take care of your skin. And that is part of preventing flares. So if you have, you go to your doctor and they try some steroids and you feel like you're not getting better, then I think it's time to go and see a dermatologist. And the reason for this is that sometimes patients start using steroids as if they're lotion or something, and they'll use them, they'll feel a little better, then they'll stop and they'll come back. And that really is because the disease is not being adequately treated. So if you find that, you can't function without using steroids all the time, then you really need to see a dermatologist.
Okay. All right. That is very helpful. One, because I agree with you. I'm one that feels many of our patients, and I have a predominantly African-American population, they would have lived mostly their entire life with that skin condition. And they will say, well, my skin has always been like this. And I'm like, okay, I'm not responsible for that. I just noticed something and I want to treat you for it. And so then I'm quick to refer to a specialist also, because I recognize you guys, having a phenomenal training, and that's just something that's not my wheelhouse. So I have another question for you. So I know you went through some of the symptoms, but I want to know, what are the most common symptoms do you see, and at what point would you recommend anything invasive, an invasive treatment modality?
Yeah. So, the most common symptom of eczema is diffusely dry skin. So sometimes patients will come into me, and I'll tell you, particularly patients with skin of color, we're very concerned about hyperpigmentation, right?
Yeah.
Someone will come into me and they'll say, hey, doctor, I have this hyperpigmentation around my eyes that really bothers me. And then I'll look at them and I'll say, oh, that's eczema. They don't realize that, but I see that, right? And so it's basically that sometimes hyperpigmentation in our skin is as a result of inflammation, this kind of smoldering eczema that you might just notice as, well, they'll say, well, my eyes are dry or my skin is dry, but I don't have eczema. but they do have eczema. So the most common symptom is extremely dry skin that is not responding to you using moisturizing creams or lotions. Okay. Other things that we can see, particularly in skin of color, is like a follicular prominence of their eczema. So it'll just look as if they have goosebumps all over their skin, but those goosebumps will be dry and rough. And that's because that's their eczema kind of aggregating around the follicles. Another thing that we see more commonly in skin of color is something called prurigo nodularis. And prurigo nodularis are dark, hard bumps all over the skin. And that happens when people are chronically itching the skin and they may get into a pattern of repeatedly picking a specific area that's itchy. And the skin responds by kind of putting a hard shell over itself. So that's another symptom of eczema that people often don't recognize as eczema. Now, one of the things I mentioned earlier is that when you have eczema, your skin barrier function is impaired, right? And so that means that infections can get in, right? So another potential symptom of eczema that people often don't recognize is skin infections, right? I think 2 weeks ago, I had a young man come in. He had a fever, he was shaking, and what he had was something we call erythroderma, but which is extremely severe eczema, right? And that made him look as if he had an infection. It wasn't an infection per se. He had super infection of his skin and he had severe eczema. So eczema can be really nuanced. Sometimes we see it in the scalp more often in people of color, and we think of it as just bad dandruff, but that is eczema. So I guess I want patients to know that the key is itch often, hyperpigmentation potentially, and just kind of feeling uncomfortable in your skin. And it makes me sad when you say patients say, oh, my skin's always been like that. But then itch is really uncomfortable. Itch is has a similar level of discomfort as pain. We know that. And so you don't have to live that way. That can be treated.
Yes, I know. It saddens me also. So are there certain areas, I know you mentioned some in the scalp, are there certain areas that are sort of classic areas that are more commonly inflamed with patients with atopic dermatitis?
Yeah, so I think this is one of those areas where we see some of the ethnic differences in presentation.
Okay.
So when you train as a dermatologist, you learn to look for eczema in the folds of the skin, the flexural surfaces of the skin. So in this area of the skin, behind the knees, in those areas of the skin. But in skin of color, it actually more often presents on the extensor surfaces of the skin. So the elbows, on top of the knees. And, I think that this kind of explains sometimes the misdiagnoses that I see. So I'll have patients come in and they'll have eczema, but someone has told them that they have psoriasis because we are trained to think of psoriasis as presenting on the extensor surfaces. So those are some of the nuances that, a dermatologist who's familiar with skin of color should be able to kind of tease out for you.
Oh, I love that. That is wonderful. I'm glad you shared that with me. I've been practicing for 30 years and I didn't know that. So can you take us through some of the most recent breakthroughs that we're having with eczema?
Yeah. So in general, I think another message that I want patients to know is that I don't want you to be scared to treat your skin. Okay. The skin is the largest organ, and the skin is an immune organ. And one of the things that we really understand now more than ever is that eczema is as much an immune disease as it is a skin disease. So, steroids, topical steroids have been the mainstay of treatment for eczema, and they still play a role, I think, for most types of eczema. What I try to do with my patients is give them a toolbox, right? And so the toolbox helps them to understand if your eczema is mild, this is what you do. If you have a little flare, this is what you do. If you have a severe flare, this is what you do. So let's start by talking about what we use for mild eczema. So for mild eczema, the go-to again tends to be topical steroids. And we have a whole range of topical steroids that can be used safely on the skin. Usually I try to have my patients limit it to about 2 weeks but up to a month if you need to. And as I said, if you use the steroids along with the skincare, you tend to get better. You tend to induce a remission, right? And then you maintain that remission by continuing to do your skincare, right? So that is kind of at the basic level. Now, one of the areas of the body where we have to be careful is the face, because we can't use steroids on the face for a long term. And there are medications that we have there. There's a classification of medications called calcineurin inhibitors, long name, but basically they are non-steroidal anti-inflammatories that are safe to use on the face and the sensitive bits. So like the armpits, the groin, and those areas. Okay.
Dr. M, don't fly by that one. I need that one again. I want our audience to get it. What is the name of that anti-inflammatory?
Yeah, so that anti-inflammatory goes by the name of tacrolimus or pimecrolimus. They have this limus at the end of them. But if you go to your doctor and you say, hey, I heard that there were non-steroids that I should be using on my face, they should be able to figure that out, even the primary care. And so I generally tell my patients, you don't want to use steroids on your face. If you can avoid it. Now, sometimes we get into insurance issues where we can't avoid it. And then more than ever, I think the patient needs to be in the care of a dermatologist who's watching them use those steroids in the face and making sure they're not getting any side effects. So steroids, calcineurin inhibitors, those have been around for a long time. So newer things that have come out, there are these medications that are called prostaglandin inhibitors. And an example of that is Eucrisa. Eucrisa is a newer medication. Again, what is the advantage? It's non-steroidal, right? So that means you're not worried about steroid atrophy, thinning of the skin, or discoloration that can sometimes happen when steroids aren't used properly. Eucrisa can be used in kids, so that's another potential benefit of that medication, but it's not that strong. Again, it's for mild eczema. And then the things that are getting dermatologists excited right now are two classes of medications. So the first one is called JAK inhibitors. And when you see those commercials on TV and they're like, ask your doctor about, this is one of those medications that's coming up a lot. They have been producing lots of new JAK inhibitors. So JAK inhibitors decrease inflammation, and they're awesome at treating itch. And that is a game changer for patients with eczema, because sometimes patients will itch out of proportion to their rash, and the itch is what's really driving them cuckoo for Cocoa Puffs. So the JAK inhibitors, there's one called Opzelura that's getting a lot of press right now. We also can use that for vitiligo. We use it for a ton of things. Everyone's using JAK inhibitors. But why I like them is because, again, they can be used all over the body safely. They can be used on the face. They can be used in the bits. And they can be used on the body to help give relief from itch and rash. And then for patients who are really ill, so that's one of the things that I want to highlight, is that sometimes eczema can really make you ill. I was talking about that little boy that I saw that was physically ill, fever, chills, came in shaking, and could have ended up in the hospital with those symptoms, right? So there's a new medication. It's about 5 years old now, and it's called Dupixent. And this is an injectable medication. So in dermatology, we use a lot of medications called biologics, and biologics mediate your immune system. So if your immune system is overactive, these medications calm down the immune system and thereby relieve the disease, the symptoms of the disease. So we have one now for eczema. We didn't have that for years, for decades. We only had those medications for psoriasis. We have one now for eczema. And what's awesome about this particular biologic is that it's not immune suppressing. So most biologics, I try to stay away from them if I can, because they suppress your immune system. And if they suppress your immune system, you have a higher risk of infections and things like that. This one, in theory, they say we don't even have to monitor. I do anyway, but it can be used in babies as young as 6 months. And for people who can't sleep, can't eat, can't gain weight, can't work because of their eczema, this is life-changing for them.
Wow, this is so helpful. So the last class of medications, is that oral or is that topical?
So JAK inhibitors can be topical, and they can also be oral. When they're taken orally, they do start to suppress the immune system a bit. But what's unique about JAK inhibitors is that they are really great for itch. Dupixent, or dupilumab, which is its generic name, is an injectable. And a lot of these biologics are injected to the skin. This one is usually injected every other week if you're an adult, or once a month if you're a child.
All right, that is very helpful because, many patients are not big fans of anything that they have to inject.
Mm-hmm.
So, and even oral, I think, is often a challenge also because they're taking so many other medications. Now, what about a typical non-steroidal anti-inflammatory medication? Is that helpful or not? Like,
so
yeah.
Oh, like an NSAID?
Yeah.
Like an NSAID? No, those are not helpful.
Okay.
I mean, the Eucrisa, NSAIDs also work on prostaglandins as well. Eucrisa works on it topically, but the pathways are not, there's not as much overlap. Now, I mean, I think in terms of things that you can take orally that can help with your eczema, antibiotics sometimes are needed to treat eczema because if the skin is super infected with staph, it doesn't matter what you put on it, it will not heal. So when I see that super infection, and for patients who are wondering, like, what does that look like? That might be your skin might be oozing. So sometimes when it's super infected, it starts to ooze, your eczema starts to ooze. You may see kind of like yellow crust on your skin. All of that is usually staph, okay? So when someone is super infected with staph, we have to treat them. If we don't treat them, they're not going to get better. The eczema will not heal. So then those instances, we add oral antibiotics to the treatment regimen.
Okay. And are we talking MSSA or are we talking MRSA? And if you could just elaborate what that is.
Yeah, so MSSA, methicillin sensitive Staph aureus, we going into deep science here. And then MRSA, MRSA, which I think a lot of people have heard the term MRSA, methicillin resistant Staph aureus. And I think that over the last 20 years, MRSA has gotten a lot of public attention, meaning that people were getting staph infections that were not responding to the typical antibiotics that we use. For most eczema patients, it's not MRSA. Most of the time, I'm not culturing it. I see it's staph, I treat it, and I treat it with the normal medications that we use to treat staph. The only time I would think about that is if someone isn't getting better, right? And if someone isn't getting better, rarely your dermatologist will culture your skin and make sure that we haven't missed something that needs to be treated more aggressively.
Okay, great. So I know you took us through the gamut, and Dr. Ip, we learned so much today. Is there a difference between someone having just dry skin and someone having eczema? I think sometimes people get confused about that. Is there a difference? And should we be treating a lot of the dry skin that we see as if they're eczema patients?
Mm-hmm. So one of the things that I do a lot of, and this might be because I'm Nigerian and Nigerians are always using parables, is I like to give analogies to my patients. And I think those analogies help to make that message stick. So what I talk to my patients about when I talk about dry skin is I say, think about a leaf in the fall and think about a leaf in the spring, okay? If you have those two leaves in your hand and you take that leaf in the fall, it's all brown, it's dry, and you can just take it with your hand and you can crush it, right? But if you take that spring leaf and you smush it, it bounces back, okay? Yeah. And so, that's why dry things catch on fire. Dry things are more fragile. We can take this to the forest, right? And say the forest fires. Forest fires happen when the forest gets too dry, right? So I like patients to understand that part of taking care of your body and taking care of your largest organ, and the way, as I said, the skin is an immune organ. So actually taking care of your immune system is by making sure that your organ, your skin is well hydrated. I've seen a lot of this in particular since the COVID, pandemic, when we had healthcare workers and everyone was overwashing their hands, right? So I'd have nurses coming into, my office with their hands looking like hamburger helper or hamburger meat, like just all jacked up. And I'm like, do you know that when your hands look like that, you are more likely to get an infection? You are more likely to make yourself sick, right? So everyone's thinking like, oh, if I wash my hands, I'm preventing infection. Well, if you overwash your hands and you make them dry and crisp, you are increasing your chances of infection. So I think the take home message is that if you see someone with abnormally dry skin, you want to make recommendations to take care of that. Being ashy, as we say in the Black community, is already something that is taboo, but there's a reason behind that beyond the aesthetics, which is making sure that your skin is functioning properly, making sure that your largest organ is well hydrated, just like we want with our body, not to be dehydrated.
That is very helpful. To your point, our patients are very sensitive about hyperpigmentation and being too dry. So I can appreciate a lot of the remedies that you're giving us. Now, we talked about the gamut of the spectrum that we can see. What about those? Are there areas that are typical for certain milder cases versus the severe cases? I'm quick. If you come to me, I'm quick to refer you to a dermatologist. I'm gonna give you a cream, and then you're on your way to a dermatologist. Just because I recognize that we don't get enough training in this area. But are there areas that you think when you get a flare up in this area, you need to come see a dermatologist sooner than later?
I think it's a little more nuanced than that. I think that eczema severity is not just about location. I think eczema severity is about the amount of involvement. So we talk about, body surface area, like how much surface area is involved. And also it's a quality of life thing. So for example, someone can come in because they have eczema around their eyes and they don't have it anywhere else. But it's so severe that they wake up, their eyes are swollen, they can't open their eyes are oozing. Well, that needs to see your dermatologist, right? Yeah. So I don't necessarily think it comes down to location per se. I think it comes down to how is this impairing your quality of life? Do you feel well or do you not feel well? And I think, again, we need to really understand that skin health is part of total body health. And so nobody's supposed to be sitting there itching all day. That's not feeling well in your skin. Does that make sense?
Absolutely. Absolutely. And I really appreciate you emphasizing that, patients will often sort of sacrifice their life. They just assume that this is normal for them. And really, when I'm doing some of the things that I'm doing, they're coming to see me about something else. And I'll just ask them like, well, how long have your skin been like this for? And they're like, well, what? Like what? Like, I'm just like, yeah, that's not normal. So, and if you were to sort of sum up sort of A, B, C, and D, sort of takeaway messages for patients, what would it be regarding eczema / atopic dermatitis?
I think it's important to recognize that eczema / atopic dermatitis can be part of a larger constellation of symptoms and things called atopy. And atopy, like I said, has other things like asthma, which we recognize there are higher burdens of that disease in communities of color, allergies, hives, and other things. So that's all, and I say they're all cousins, right? They're all related, first degree cousins. That's the first thing. The second thing is that our skin is not meant to be dry. And I think that just understanding, I'd love people to think of the skin as the first part of your immune system, right? And I think right now everyone recognizes that your immune system is a vital part of your health. So that's actually why so much cancer research has come out of the skin. It's because it's our largest organ and it's our largest immune organ. So taking care of your skin is part of taking care of your total body health. I think that if people will just moisturize every single day, that takes one big step towards preventing a myriad of different issues that can come up with the skin in terms of inflammatory skin diseases. So I think that moisturizing with thick creams, it's important to understand that creams are made with an oil base, lotions are made with a water base. So creams work better on the skin in terms of putting moisture and improving your skin barrier. Okay. And then I think the last thing is not to be afraid of medication. And I understand why there's a lot of hesitancy to treat things in communities of color. And that goes across the gamut of all my patients with skin of color, my Asian patients, my Black patients, my American patients, my Korean, everyone has a little bit of fear and trepidation. I think it's really important to get a good care team, to get doctors that you trust. I think in dermatology, what's so challenging is that only 3% of dermatologists identify as having skin of color.
Wow.
So
Wow.
you can't necessarily say, I have to find a dermatologist with skin of color. In certain parts of the country, that's just not going to happen. But having a team that you trust is a really important part of making sure that things aren't missed. Sometimes eczema is not eczema. Sometimes eczema is skin cancer. Sometimes eczema is an autoimmune disease like lupus, right? There are lots of nuances there. And if people don't have a good care team that wants to get to the bottom of an issue, then things get missed. So if you feel like you're not feeling better, then you need to continue to search out healthcare providers that can help you to get an answer to why you don't feel well.
Wow, that's very helpful. And I would also just add to that, if your healthcare provider is not advocating for you or being very dismissive, then I tell people all the time, you have to go talk to the insurance companies, tell them you're unhappy, and choose another provider where you don't feel dismissed or you don't feel looked over. So that is very helpful, Dr. Ip. Thank you so much. So is there a sort of closing message that you have for us? I know you mentioned about moisturizers. I'm gonna tell you, my male patients will be looking at me crazy, like, moisturize, like, but I do think as men, we need to take care of our skin better. I don't think we know enough, because like, even when you said moisturizer, I'm thinking to myself, what is that? Like, where do I find that? What aisle is that in?
Yeah. No, we've got to change that for sure. You will not catch me out without any moisturizer. I think that my take-home message is actually not about eczema. My take-home message is about skin health, right? As I said, sometimes that eczema isn't eczema. Sometimes that eczema is lymphoma. Like, that is something that happened recently with a patient of mine, a woman of color, a Black woman who'd been seen by dermatologists for years, a European American dermatologist, and was told, this is eczema, this is eczema. And I saw her and I was like, this is not eczema. That was lymphoma, right? So I just, or other things, sometimes people with skin of color, oh, I don't wear sunscreen. And then I say, well, did you know that Bob Marley died from melanoma, right? That's what Bob Marley died from. He died from melanoma, which we think of as a disease of, a cancer for people with fairer skin.
Yes.
And so I think the most important message for me is that your skin health matters. I have been able to diagnose liver disease through the skin. I have been able to diagnose cancer through the skin. I've been able to diagnose autoimmune disease through the skin. The skin, to me, tells a beautiful story, and it is, covering all of our organs and has a connection to all of them. So ignoring your skin health could be jeopardizing your overall health. That's my message.
I love that. And I just want to thank you, Dr. Ip. This was so informative. I know our audience will, just really, really benefit from this. I feel like a lot of the providers that follow us also will benefit from this. And that is a great takeaway message. I also want to thank our audience for tuning in. I want them to know that this webcast will be made available through our atopic dermatitis channel that we have on mdnewsline.com. And I want to thank you for your time and for your expertise. And you're very relatable. I love that. And this is why we need more physicians that look like you to have at our disposal. So I want to thank everyone. Please be sure to follow us on Twitter, on Instagram at MD Newsline, and also visit our mdnewsline.com today. And please log on. Dr. Ip will be on there, and we're excited. And we look forward to talking to you again, Dr. Ip.
Excellent. I also wanted to share that patients can also find me on Instagram at vibrant_skinbarmd. And on my Instagram, I do a lot of videos. I show a lot of content pertaining to all skin types, but also, particularly skin of color. My website is vibrantdermatology.com. And I also wanted to let people know that there is a website created by a colleague of mine called Black Dermatology Directory, right? And so that is a really great resource because she took the time to find out where we all are all over North America. So there are even doctors in Canada there. There are a few in England there as well, but that's a great resource for people who are looking for a dermatologist with skin of color.